Appreciate it. Appreciate it. Well, I just want to make sure we have our panelists, and I want to pin them too, so that you also see them. Let's pin them to the top. We have Claudia, Geoffrey, Jack.
Here.
And who am I missing? See, now that I'm pinning, I don't see the whole gallery.
I'm here.
Go back to gallery. And there's Sonny again. Here we go. And then, unfortunately, Don Wright won't be with us today. And Brett Harnett, where are you? Let me get back to gallery.
He's here and he's waving.
I am here.
Yes, there he is. Thank you, Brett. Thanks for making it easy on me. Okay, we have our beautiful panel here. Laura, just give me the word, or Jack, and we'll get started.
Whenever you would like.
Stephanie, I don't see Claudia. I see Mary Beth instead.
Oh, I pinned Claudia, so she should be in the middle of the screen right now or above. Let's see,
Not for
gallery.
me. Am I looking at the wrong view? Gallery.
Maybe I need to speak. And now you
Yeah.
speak.
Well, you should
See
be
a pin?
pinned, Claudia.
I have a pin, so if you go to gallery, you should see Claudia with Geoffrey, Jack, Saundra, really Sonny, and Brett, who's kind of out of the picture at this moment.
If you click on pin, does that put her to the top?
Mm-hmm. But
No,
if you
now-
change your view to gallery, you should see, or let me see, view to speaker, you should see all five.
Okay, because I pinned her, I see her, but now I don't see. I don't know why I've got Mary Beth is between Sonny and Brett, and Jack's not there.
I am here. You don't.
Maybe it's just me.
Does everyone see the five of these lovely panelists pinned?
No.
Okay,
I see
thank you for
everybody.
telling me. Well, let me pin them to, let's see, I pinned them in the first screens for you, so let me pin them in the second so you can see. Pin the second screen. Okay. Well, Jack, go ahead while I'm doing this.
It's all right. I'm just worried about the recording, what
Yeah.
the recording is going to show.
Yeah. Okay.
Well, while Stephanie and Laura are playing with our very own digital health tool, I'd like to welcome everybody this morning to a roundtable discussion on digital health tools sponsored by TCN, and TCN stands for the Collaboration Network. It is part of the CCTST Center for Improvement Science. TCN has been around for many years and was originally started as a way to bring people from a lot of different disciplines and throughout the university and even in the community together to form interdisciplinary teams around grant opportunities we have
Join the
in
meeting.
the health area. So it has morphed into a number of different areas, continues to meet bi-weekly, but periodically we have chosen topics that are of wide interest and put together panels as you see today so that we can more broadly offer information and discussions about particular topics. Today's topic is digital health tools. This is also partially sponsored by the Community Engagement Network Initiative, which is a task force that is currently working within the CCTST to disseminate more widely some of the things that are going on within the university, including Children's Hospital and UC Health, and engage the community in discussions about these topics so that we have a more balanced perspective of some of the things that we are researching, and the community is aware of things that we are doing within the Academic Health Center that can benefit them. And it also promotes sort of joint research projects that that we've had the opportunity to do. So today we are going to be covering, as I said, digital health tools, and our panelists are on the screen today. You can see. Unfortunately, Don Wright had to deal with a family emergency and will not be able to be here with us today. But the other presenters are here, and I just want to briefly introduce them, give you just an overview of what they will be talking about. You can see their titles up there, so I won't go into that. But Regan is going to be discussing how the current COVID pandemic has accelerated the use of some of the virtual reality simulations, from in-person to headsets to online computer scenarios, and educating learners and primary care providers about some of the social determinants of health, and providing care for underserved patients in the Medicaid realm. So she will be covering a wide range of things that impact education particularly. Geoffrey Pinski will be discussing how technology transfer at UC can help researchers create impact with their digital health tools that they're experimenting with currently. He will share the resources that are available with some real-world examples. So for academicians that are in this space, one of the most challenging things that we have is to find ways to transfer that research and technology out into the real world. So we welcome him, and I think we'll learn quite a bit about how to make that bridge. Claudia Rebola will be discussing the design of different digital health therapy tools for cancer survivors and brain tumor related and quality of life. So she'll be talking about 4 application tools that they've been working on at DAAP, and I'll let her go into the details of them. They have acronyms that I won't attempt at this point to pronounce, but these are applications that have been developed by a transdisciplinary team across the colleges of Design, Architecture, Art, and Planning, DAAP, Arts and Sciences, Medicine, Claremont College, and the Brain Tumor Center at UC. The significance of the work is to join efforts for impact and placing technologies and health into the hands of users while advancing research through various design practices. So this is probably one of the most wide-ranging and most diverse teams that we have in this space, and it's always interesting to see how we bring the art and design parts of our brains together with the science parts of our brains in projects like this. So this will be a very interesting presentation. Brett Harnett will be providing an overview of 3 tools that are available through health informatics, and facilitate COVID research, analysis, and publishing. So Brett is responsible for the Center for Health Informatics, primarily associated with UC Health, where we have amassed mountains of data, but accessing it and using it practically has always been a challenge. So we're really interested to hear some of the things that Brett has been working on in that area, and ways that researchers and other individuals actually can access this huge data set in a practical way for our current research practices. So with that, I'm going to allow us to move forward, take a look at today's program, and to get started with these presentations so that we can get into some of our breakout rooms to talk about some of the practical uses of the things that we'll be hearing about this morning. So Stephanie, I'm going to turn it back over to you.
Okay. It looks like we're starting with Saundra, so let's let Saundra share her screen. I know you want to do you want me to share your video, so let me know when you want me to share your video. You need to unmute.
He's on mute.
No, you know, it's like, how do I share again? Okay.
Right. That's okay. Take your time.
I will.
I'll stop sharing, so that'll help too.
Yes. I wondered why. It was like, why isn't it sharing? Okay.
There we go.
Okay. From the beginning. All right. So I'm going to be talking today about learning about social determinants of health and different patient populations, primarily seen by Medicaid physicians and other providers during COVID, and some of the digital tools that we then came to use as a result. So this program is funded by the MedTap Equity Simulation Initiative through the Ohio Department of Medicaid. These are my views and only mine, and are not attributed to the Ohio Department of Medicaid or to the federal Medicaid program. The PI for this project is actually Susan Brammer, who's an associate professor in the College of Nursing, and I am her co-PI in the College of Medicine. And all of the simulation work is done by the Office of Research Simulation IT Division, directed by Chris Collins. All right. So back in 2018, 2020, just to give you a little background, the Ohio Government Resource Center and ODM, Ohio Department of Medicaid, put out a call for virtual tools to train Medicaid providers, because they didn't feel as though Medicaid providers had enough about cultural competency, implicit bias, social determinants of health, which at the time, was just bursting out onto the scene. And so we put in for 2 virtual simulations to teach providers about social determinants of health. And our 2 scenarios were one about a young man with schizophrenia and asthma, and our second was an older woman with limited English proficiency and multiple health issues, hypertension, chronic obstructive pulmonary disorder, all those things having to do with the heart, plus diabetes. And at the time, you would put on a headset and you would take the controllers and you would become the player in the game. And so you would go through each scenario. It would tell you kind of where to click and where to move. It was kind of like being in a movie, though, because people were talking to you. And we didn't have a lot of the technology to actually play the game. You were just kind of playing through the game. So that was evaluated in over 270 healthcare workers around the state of Ohio, and I mean around the state of Ohio, where we traveled, I think it was to 60 of the 88 counties in Ohio to show this and evaluate it in primary care practices and Medicaid FQHCs and so forth. So come 2020, actually it was March 5th of 2020, we were in Cleveland at Metro Health showing this, and we were just starting to hear about COVID. So we went back to our homes, and a week later, everything closed down, and we kind of sat there for a minute, for a month or two, going, okay, now what do we do until July, when the project actually ends? And I know ODH was also scrambling to figure out, what do we do with these headsets that we bought for everyone and all this equipment and so forth. And basically, the big word back then was pivot. We're all pivoting to virtual reality. We're all putting our things online. We're pivoting our classes and so forth. So we took the simulations that were meant for headsets and the hand controllers and converted it to a completely online scenario that you play on the computer. And I'm not sure if this will work or not, but this is, if you click on this, which obviously it is not. Oh, yeah, it is. Can you see that web page or no? Probably not. Okay. We'll just go back.
We're good. We can see
We're
it.
good. Oh, okay. So this is the Medicaid Equity Simulation Project just for us. But if you go to the Ohio Department of Medicaid and the Ohio Government Resource Center. You'll see them because every one of the 7 colleges in the state of Ohio did these simulations, and each of us did 2 or 3 of them, and they're on all different topics. And so you can go and play through each of these if you wanted to off the government resource page. But it just tells you a little bit about your project overview and what it was about, your case studies, what it involved, and so forth. And you basically click and you start playing online instead. So let's go back. How do we do that, people? All right, hold on.
Go back to your.
Yeah, I know.
You got it. Yep.
All right. I hate that bar. It's always in the way. Okay. So we're done pivoting now, and we're into 2021. And now they come out. We're going to still do this. It's going to be completely online. And we're going to tell you what simulations that we want you to do. So we want you to do at least one simulation with a patient who is LGBTQ. And we want to do one simulation with a child or adult patient with intellectual and developmental disabilities. And then you could choose any other patient with another condition that is commonly seen by Medicaid providers. Oh, okay. So what I want to tell you that was different about this so far is that from the bottom to the top, everything has been about community engagement. So creating the characters, the scenarios, the scripts. We have interviewed patients with lived experience in each of these areas. We have interviewed their caregivers, whether they were family or private. We've engaged community organizations that work with persons with disabilities, advocates for LGBTQ, people who educate about LGBTQ, to providers, to medical schools, to medical students, nursing students, etc. And then also the providers themselves have been engaged. And then, of course, us, our academic researchers and the simulation people. All right, so we get into our scenarios. I'm just going to show you, or Stephanie's going to show you some very short clips of the 3 different scenarios. It's about 2 minutes it takes, and it just kind of rushes through. It's very dark because we're still trying to get to where we need to be. In fact, if you came this afternoon at 5 to our advisory board, you'd see much more. However, Medicaid is asking us to put these disclaimers in front of each of the sims. So the first disclaimer about that it contains content that some people may find triggering. So if you believe it will trigger you, you may choose not to participate in it, or you can withdraw at any time. Some of the scenarios around the state had to be toned down a little bit because they felt like it was a little too much. And then ODM decided to put in the medical practitioner conscience clause. So that goes in front of all the LGBTQ scenarios. So they'll have the first disclaimer, then they'll have the second disclaimer, which is basically that practitioners, institutions, healthcare payers have the freedom to decline, to perform, participate, pay anything that violates their conscience as informed by their morals, ethics, or religious beliefs or principles. And that was law signed on July 1st and went into effect September, I can't see because my bar is in the way, but September 20 something, I think. Thank you. September 30th, 2021. So that will now be in front of all the LGBTQ scenarios, which I can tell you that our patients with lived experiences were not extremely happy about. However, they still want to be involved in the project, and so they're going to continue to go forward. All right, so I think I'm going to have Stephanie play. Yes, Stephanie is going to play.
I love it. It has my name on your slide. Okay.
So do I stop share for a minute?
Yes, please.
Okay.
Yes, if you don't mind.
I do not.
And I will share. Oh, Poor Brett. Here we go. I'm going to put it back on this screen over here on number 2. Thank you, Brett, for your patience. I had it ready on slide. Let me do the slide. I had it over here ready. Let's do this on the other one. Oops, my bad. Just a second, please.
I don't feel as bad now.
Well, it does take technology.
It
does
does.
take time, everybody. Digital.
Am I supposed to be doing something yet?
No, Brett, you're just on my second screen.
Okay.
And my tools are all getting out of control. Here we go. Okay. New share on 2. And let me turn the computer audio on too. Oh, apologies, everyone.
I'm sorry. It'll be
No,
starting when all
don't
this
be,
is
don't be. Don't be. My taskbar doesn't like to be on at this point either. Okay, let's try this. Can everyone see this? No? You can hear it?
I need to sign.
We can hear it, we can't see it.
Okay, thank you. Thank you, Jason. I know that voice. Go back a little bit. Apologies, everyone. It's almost there.
I need to sign in and go to my cot so I can get warm and sleep.
We can hear sound and not see it again.
You're coughing. Who died? And
You were
left
good. You were good where
my
you were
bed,
before.
My stuff I left here.
Hey, lady, you want some company?
And it's only 2 minutes.
This
We're a
is
little
when we
bit ahead of
realize
time.
that it's 2021 and we haven't figured out how to make a screen work as an extension of our computers. In 2022, my goodness.
I know it's my apologies. 2 screens and one last time. I've got the computer, but I need the. Okay, here we go.
And go to my cot so I can get warm and sleep.
No.
Excuse me, you need to back up off of me with your coughing.
Who died and left you, God? Let me go to my bed.
There it works. Perfect.
Thank you for your patience.
We're not gonna tell her.
Or Stephanie, we're not getting sound. Can you back it up? Wait, all the way.
Maybe we should just read the subtitles and go through the pictures.
Here, someone muted me. I'm sorry, someone muted me. Can you hear again?
No, we can't.
No.
Just go through that. We're taking up too much time. I'm sorry.
Now we lost the picture.
Maybe we should just go on, Stephanie. Really? I can send the link. I can send the YouTube link.
I can put the link in the, I apologize.
There we go. No problem.
It is a great video, though, to see the simulation, the scenes, the situation, and be immersed in the situation. So that's very good.
Thank you. Yeah, so it just shows a very short clip of the 3 scenarios. Sharon, who's homeless and has is experiencing an active episode of her schizophrenia, and then Laura, Crystal Epps, who is a transgender woman, who's transforming from male to female. She hasn't had her insurance for very long, and it's the first time she's seeing a Medicaid doctor who will take her and actually provides care for transgender patients and is very comfortable with it. Not her staff yet, but she is. So it shows some of and in these scenarios, you get to make choices. You can choose what's going to happen if I go into the male bathroom versus the female bathroom. What's going to happen if Brian and his mom are late to their appointment? How is the staff going to treat them as far as, finally getting them back into a room? And how adult primary care practices are really not set up for patients with disabilities, unless they have been specifically set up as a transition clinic where you're going from childhood, where you've seen 5 different specialists, to a primary care doc who's going to coordinate your care with those specialists and see you for most of your care. And, kind of the trauma that causes to the mom. She's taken care of her son this whole time. She's got, binders full of his medical records. And, what does she do with all of these? So let's see, my very last slide, I think. I can go back to my PowerPoint. Let's see. I'm probably not sharing now, am I?
No, I was.
We'll just go on. Okay. That's okay. So anyway, we're in our stage where tonight we're gonna kind of go through most of the scenario of each scenario. Our whole advisory committee will be there, in addition to the advisory committee that Medicaid has put together, which is also patients with lived experience and their caregivers, in terms of these different categories. And then everybody's going to make comments. That's what happened 2 weeks ago. It's like, change this, this is offensive, don't say it this way, say it that way. So it's been a really interesting experience, and I hope that by April 1st, we're going to have a really nice product of 3 different online scenarios that we can share with people that then will be taken statewide to providers that provide Medicaid. So that's all for me. Sorry I took up so much time. Okay, I'm done.
Right on time, Sonny. And I think we have Brett next.
I'm ready. I guess I will share my screen.
Yes, if you don't mind.
Mm-hmm. Okay, I may have to switch the settings here. Do you see full screen?
Now we do. Thank you.
Okay. I just got to do a little display gymnastics. Good morning, everyone. As Jack pointed out, I'm going to spend a few minutes to talk about some of the tools that we have developed in the College of Medicine that are specifically, or at least partially specifically, dedicated to COVID research. I have quite a few slides, I think about 27, but there are a lot of screenshots, and I'm going to narrate as I go through, so you have a pretty good idea as to what's available, and some of these things are fairly new, actually. Let me also state at this point, I have no financial disclosure or conflicts of interest in any material in this presentation. I just work here. All right, we're going to cover some of the resources at the College of Medicine. These are 3 specific tools that I'm going to highlight for you. The first one is called Covidicus. This is a local repository from a study that is initially including this Cincinnati COVID repository. This is a study by Maggie Powers and Kristen Hudak, but it is scalable to other studies that can be ingested into a centralized data source for UC Health. I'm going to talk about the National COVID Collaboratory, code name N3C. This is a national NIH-sponsored, driven by NCATS, a sponsor of our CTSA award. And I'm going to also cover the Trinetics Research Network. That's a global research network. It's a local tool that can scale far, far beyond our domain. So we'll start with Covidicus. So we have, this is a tool that was built in conjunction with Children's Hospital. One of our developers, John Mikan, has been working on building this interface that allows you to basically identify subjects of interest and then drill down into the details of the clinical data to specify a very specific population. So what we have here is a repository of patients that come out of UC Health and through right now the CCR. If these are consented patients in this particular repository, and on the left-hand side is our menus, and you can see we have basically what this is, how to use it, what type of data is in there, and then specifically the data elements that you can click and select: demographics, admissions, diagnosis, flow sheet data, medication, administration, medication orders, problem list, procedures, procedure results. And then each of these can drill down. You can see this particular screenshot. I clicked on procedure results. You can see these are some of the details that are built in there. And what you do is you select and move over into the next interface those types of clinical characteristics that you're looking for to find the initial set of patients. And notice here it says 146. Now, as we want to now only include positive tests. So we're in this particular example, we're interested in not everyone who has had a test or was not diagnosed with COVID, but those who were diagnosed with COVID. And there's a couple of ways we can do that. It's either an ICD-10 code or it's a positive test, such as PCR test or antigen test. And notice as you click and you add more elements, the numbers get smaller. So now we're going to say include positive tests in the last 30 days. So we're only interested in the, say, the most recent set of COVID tests. And now we have here 119. Again, this is our local population. This is not a repository outside of UC Health. So you see here we have set 30 days. And then we have a histogram. This is obviously updated, not recently, but then we continue to browse down into other data. We can go into race, for example, and we can choose those, and those are specified by this shaded area. Graphically, 11 subjects, 911. We've totaled 22 patients now as we drill down to choose racial characteristics. Once we find the specific set of patients that we're looking for to drill down into, we can we have a screenshot. These are all synthetic codes. This is de-identified. The data can be re-identified with proper compliance formats. And there's a summary over here. And we have these 22 patients. And finally, we can export the data out of here. this isn't not designed to be an analysis tool. I mean, there's quick summaries, a histogram, for example, or some graphs, but it's not really made for analysis. So you can export data into, I will loosely say Excel, but that may be a kind of a go-between format, or specifically a tab separated format, comma separated. We can export it into SAS and R and whatever analysis tools that you and your team are using. So here you can see up here, we can export as a comma separated value. So that is the first tool, locally hosted here at UC. I want to talk now about the National COVID Cohort Collaborative, or N3C. This is the largest national central repository of COVID patients and match controls. The BMI has been contributing to this initiative, which is driven by NCATS, which is our sponsor for our CTSA, the CCTST. So we were highly encouraged to join this network. And what that means is we collect data in Epic every single day. And then every other week, we export data into Trinetics, which is the third example I'm going to show you after COVID. But Trinetics is involved in this because it's the on-ramp. The on-ramp for uploading data into this N3C. So when we do that, we have scripts that run every other week. It extracts all of the required elements for the requirements of the N3C, as well as 2 match controls for every COVID positive patient submitted. But what's interesting about this is that it is taking a different approach in terms of how you would manage COVID data and how you would access it, how you would analyze it. So they've built this system, the NIH built this system for expeditious data and knowledge sharing. They note that though medical records are abundant, they're largely inaccessible to outside researchers. Every institution has their EHR, and within those institutions, it's usually fairly easily accessible for your local population. But if you want to share that data across institutions, you run into a myriad of challenges, most notably HIPAA and other requirements. So there has to be a different way to get this data into a centralized source where it can be shared and put to good use. The other interesting thing about N3C is that it is built to be a big data platform. And you'll see, I'm going to give you an example of some of the numbers that are in there currently. And it's designed for data science approaches. So that would be things such as artificial intelligence, machine learning. I'm not going to say natural language processing because we are not uploading notes. But to the ability to heavily utilize onboard analytics, what we call application servers within N3C. The data never leaves N3C. All of your analysis is done within N3C because what eventually happens is we and all the other organizations submit what we call a limited data set. And that means it's de-identified except for we include specific dates. So therefore, it's still considered PHI according to Health and Human Services and the privacy rule. But you can't do temporal analysis without specific dates. You need to know when someone got sick, how long they got sick for, what other diagnoses did they have? Did they have a vaccine and then they didn't get sick? They did get sick. They ended up in ICU, ventilation, all those things. Very timely oriented. We call them temporal sequences. So this is the homepage of the N3C. and it talks very at a high level, kind of what it is, and some of the statistics to date. And then on the right-hand side, I listed there the partners. That includes NCAS, CD2H, PCORNet. Everyone has probably heard of PCORNet, the ACT network as an NCAS program. Odyssey, which is the data model that N3C uses. N3C uses this model called OMOP. It is powered by the Odyssey network. Basically, it's a common data model. So no matter how you upload your data, how you store your data locally in your data warehouse, for us it's Trinetics, it gets transformed and harmonized into this OMOP data model. Because if you're bringing in billions of data points, if they're not the same data standard, is not going to work. So they use OMOP. And that Trinetics, as I mentioned, is our on-ramp to uploading this data every other week. And so we upload to Trinetics anyway, and then they take a subset of the data, the COVID positive patients and the match controls, and it gets pushed up to NIH. There are currently 285 institutions across the nation who are subscribed to this. Children's is also subscribed to this. We have been uploading data to N3C, I think since March of 2021. I can't remember exactly. I am the designated point of contact for N3C. All 285 institutions are not supplying data. I think about 80 are. So basically, you can access the data and you can upload the data. We do both. So we've been updating the data since March 2021, and about I think 2 months ago, we were finally provided access to it. So there's two steps there. You know, you upload the data, and then anyone can institutionally can apply to access what we call the data enclave. So the data enclave allows you to actually get in and see the data. I'm not going to get very deep into the technical characteristics of the N3C, but there are 3 levels of data. Level 1 is, they call it custom. This is synthetic data. This is computationally derived data. It's focused on kind of giving you a tool set, some training data for you to understand what this is, and that way you're not hammering the data source with big queries where you're just trying to learn the system. It's very dense, very complex, and we have one of our analysts, Leslie Lee, who is learning how to navigate the data interface, and she's working with Maggie Powers as we've set up a kind of a training methodology with Maggie. So Maggie's on the scientific side, Leslie's on the data side, and they're working together to try to figure this out. And then we're gonna map out some processes and some best practices that people can use. But you typically, I would advise people not to go in here without us, at least initially, until you learn how this works. It's not a small feat to understand the system. The second set of data, that's where we get into the OMOP data model. This is a de-identified data set. It's based on the privacy rule, de-identification standards, zip codes, dates of service are date shifted, so we don't have actual dates. So again, there's certain things you can't do, such as temporal sequences with a de-identified data set, because the dates are shifted. That's not going to work when you're looking at temporal analyses. What we have on the third level is the highest level of data. This is the limited data set, and that includes actual dates of service. Most of the people supplying data are doing this, some don't, for whatever reason. You can also put in zip code if you're looking to categorize people by geographic stratification. And what you need to actually do this is you need an IRB protocol. And we have, as an institution, a single data use agreement for UC, and that's what I kind of oversee. And if you want to access data, you have to get a data use request. They're called the DUR, and then you can get in and associate with a project or create new projects. This is we're still learning this system. It's like I said, we just got access to it less than 2 months ago. But anyway, here's the current corpus as of a couple of days ago, I think. We have almost 4 million positive patients from 69 sites. Okay, I couldn't remember how many sites were contributing. I thought it was 80. It's 69. We have over 11 million total patients. Those would be the match controls. There are 12.6 billion rows in this architecture. 587 million procedures, 1.9 billion drug exposures, 6.10 million visits, 1.1 billion observations, and 6.1 billion lab results. I think you can see now where we're talking about big data. I'm going to speed up a little bit because I know I'm at 17 minutes and I was allocated 12. Laura said I can have a little more because we're missing one speaker. I'm going to try to keep this to about 22. Laura, is that okay? Or do I have to speed up? Laura, I can't hear you.
Sorry, Stephanie, are we okay on time? Stephanie might be out getting a coffee. I think it's fine.
Okay, I'll speed up a little bit. So now we're getting to some of the details, technical stuff. I don't want to spend too much time, but there are projects, there are existing projects, and I'm not sure how many there were. It's something like 160 existing projects. So you're looking at a particular phenotype and outcomes and et cetera, et cetera. You can also create your own project if one of the projects you have is not already presented. And the advantage of having an existing project is that you can look at this phenotype explorer, what other people, some of the ideas, some of the hypotheses that were generated by other institutions that might go, this is interesting, I want to join and add my input to it. Here's some of the projects predicting long-term psychiatric effects, COVID, chronic pain and long COVID-19 survivors, long-term. Obviously, this is filtered on long COVID. See right there. So these are just some of the projects, and this particular search was for long COVID. This menu on the left gets really dense. That's what I'm talking about. Getting into the weeds of this system is not for the faint of heart. Then you get into some of these, what they call the contour analysis tools. These are some of the analysis tools that are built into the application servers. The data does not leave M3C. Everything is done on board. Just step-by-step visualizations, tools, transformations, histograms, graphs, things like that. And then there's a few others here as well. So this is a pretty dense system, and it is the largest in the nation. This is not international. This is just the US, sponsored by NIH. Now, I also hear that they may begin expanding this into other phenotypes as a result of long COVID, and drill down into other things such as I have chronic kidney disease. I have no history of it. I'm not sure why I got it, but I had COVID last year, and maybe it's associated. All right, so I'm going to jump now to my third example. This is Trinetics. This is a lot of people are familiar with Trinetics. A lot of people use it. It's our cohort identification tool locally here at UC, but it does two things. We supply data to Trinetics, as I mentioned earlier, every other week or so. And what that does is that our data is presented to the pharmaceutical industry. And the pharmaceutical industry, should they subscribe to Trinetics, that's their business model, can search across, it's something like now 160, 170 organizations that are contributing. And they would put in the inclusion exclusion criteria, and then they would rank what healthcare organizations have those patients the more patients come up at the top, and it gets narrowed down into a funnel. So over the past 6 years, we've been offered over 150 clinical trials, and we've taken about a third of them. So it brings in clinical revenue from the pharmaceutical and CRO world. But the other thing about Trinetics is that it's a local cohort identification tool for the UC Health population. And I'm going to go beyond that with the research, and that's the global network. So this is the ability for researchers to use the same interface that the pharmas use to explore, analyze, and to publish. So this is an example of if I'm looking for people with COVID, I can simply search. This is the UC Health network. I'm not sure when I did this, fairly recently, I think. But we're looking at people who we want to know who have COVID, and what would happen if we were trying to figure out who had chronic kidney disease after having COVID. So what we do then is we do, this is also a temporal query, and I'm not sure if you can see this or not, but we create two groups. One is a temporal constraint event 1B. This is chronic kidney disease. It has to have happened after someone had a diagnosis of COVID within with at least 3 months after. So basically, did someone develop CKD 3 months after having COVID? And then if we do that in this interface, we see we have 340 patients. So 340 patients at UC Health develop chronic kidney disease within 3 months after a diagnosis of COVID. However, that's interesting perhaps, but we are part of the research network for Trinetics, and that means we agreed to share our data with the global network, and in return, we get to see the global network. So if what we do is we take this query, we run it locally, it's very fast. And then we simply choose a drop-down menu here. Notice right here, this is local 1 HCO, University of Cincinnati, this is UC Health. I switch to the research network. I hit the count patients button, and now this exact same query, how many patients had COVID, chronic kidney disease 3 months later, now we have 18,853. Notice here, the UC Health, we have 1.2 million patients. The COVID, the global network has currently 86 million patients. So now we're looking at generalizability. And this is all done on board. This any researcher who has access to Trinetics can do this, and there's no cost. What you do once you're in there, people are probably familiar with this. You get your basic demographics. They have other drill down tools when you explore these cohorts. You have diagnoses beyond what you were specifically looking for that particular patient group. You have all the medications of that patient group, all of the lab values of that patient group, all the procedures of the patient group, and you can drill down even further from there. A very interesting capability of Trinetics is it has onboard analytics, kind of like N3C, but it's not as tightly wrapped up as N3C. So you can analyze outcomes, compare cohorts, treatment pathways, incidence and prevalence. So these are all things that you can do when you build your cohorts and you want to compare cohorts. You can simply do an analysis and see what the outcomes are. We're starting to see papers being published using this data of real world evidence. This is a paper published a few months ago. Actually, it was in 2021, sorry, April 2021, out of the UK, doing a 6-month neurological study of COVID patients. And notice here, Trinetics EHR network with over 81 million patients was used. So they simply used the research network to access the data to do their analysis. We're in the process of putting together a study feasibility and publishing standard for Trinetics. So this will help you a guide on how you use Trinetics, how you access the data, how you run the analytic tools, and how you can publish. And that includes the publishing guidelines outlined by Trinetics. I'm going to mention very briefly that we can also access data we can actually download data. So you can do a lot of things on board, but you may need to go deeper. You need to run it through your R or your SaaS platform. You can actually download the data, and that it's probably millions of rows of data that can be imported into your statistical package, and you can apply your scientific rigor to it, and then publish papers. And I think that's what that paper in the UK did. They actually downloaded the data. There's a lot of rules with that. I'm not going to go into that right now. Okay. Any questions?
Great.
I know, a lot of words.
As Laura said, and we thought our metrics spreadsheets were unmanageable.
Yeah, it gets really dense, and I think this N3C thing is going to be very interesting. We just need to spend some time to get into it.
Jason does have a question for you. He has his hand
Who?
raised.
Jason?
Jason
Hi, Jason.
Blackard.
Hi,
Hey,
Jason.
Brett. Good morning.
Morning.
I think I know the answer, but I'm going to ask you anyway. When you're talking about Trinetics and NC3 and some of the other data sets, can you just make sure that I understand what your role is versus other people's? Because I think sometimes I think of you as the PI or a co-PI along with me or someone else, but I wonder how you think of yourself, because I'm not sure that you need to tell me. I don't know how active you're supposed to be in this process, or if I'm just supposed to come to you and say, give me the data.
Yeah, if you're talking about me specifically,
well, you and your group, sorry.
Me and my group, my group. So we if you need, if you're submitting a grant and you want informatics expertise on your grant as a co-investigator, I do that a lot as a faculty member, and I do a lot of 5% things. I'm on numerous grants of 5%. You know, I'm included. But I think the question you're asking is more about with BMI and how you interface with all that stuff. Like I said, these are the first tool, Covidicus, is not a tool that you go in and use yourself. You say, I want to go in here. You then work with our services. We then partner you with an analyst, and then we'd help you find what you want and then give you your data. You do what you want with it. Kind of the same thing with Trinetics. Trinetics is all self-service, but if you want BMI's help, you could, with query building, for example, we can help you with that. Okay. If you want to get data, we have to help you get the data. But a lot of things you can do right on board without us at all.
Okay. Perfect. Thank you.
And N3C is kind of a similar thing. I would not recommend going into N3C alone first. We can help you because we're training on how to do that. And okay. Once you get the data, we can help you.
Okay, that makes sense. Thank you.
Okay.
Thank you, Brett. We're going to move to Claudia Rebola now. Thanks, Claudia. And I'll ask you to.
All right. Yes. Okay, perfect. You know what I'm gonna do? I'm gonna try to tell people that, okay, there we go. Excellent. Okay, so let me compact this thing here like that. Actually, let's do like that. Okay, so I'm gonna talk about the can of digital health and quality of life. And I'm gonna do it in a way of our journey of collaborating with Shoma Sengupta from the College of Medicine, Brain Tumor Center. I have spoken about this before, that it was very interesting, our collaboration, in which she came up with an introduction via, other colleagues, and the significance of our work was collaborating across our disciplines to truly exercise design for clinical trials. And with Shoma Sengupta, we started entertaining ideas around this question: how we can advance new digital therapy tools. Let me go back. New digital therapy tools for cancer survivorship and brain-related diseases for improving quality of life. And the idea was, to think about, there we go. The idea was to think about, look at all these animations that are not working today. So the idea was to really think about how we can design tools that allows us to impact the quality of life of our patients, but at the same time, these tools allows us to do exploratory research at the intersection of medicine and design, and how we can design technologies at the hands of users to again, improve quality of life. And one of the first conversations that we had in our collaborations and brainstorming these possibilities of designing this tool was around music therapy. And our first tools that we designed is called ARMCAN in turn, and there is an acronym behind ARMCAN, Active Responsive Music Therapy for a cancer patient. So we decided to partner with researchers that were doing interesting work on music and medicine and how we can bring it to the breast cancer population in trying to address the issues of chemo brain, not using this therapy tool as treatment, but as part of a therapy tool that allows us to possibly reduce the number of chemotherapies and reduce chemo brain when a patient is going under treatment. So here's how our study was born. Is currently enrolling participants. The use of active versus receptive music listening to reduce the neurocognitive symptoms of chemo brain breast cancer patients. We develop a tool. There are different ways of developing an application tool. We are still at the stage of being what I call in my design world a low fidelity prototype with basic functionalities to be used in digital devices such as an iPad. And we have ideas how to keep expanding this music therapy tool. These are some snapshots of the interfaces that allows us to engage with participants in our research study. This is a quick animation in showing, for example, how someone can choose a genre and interact with some functionality. There is no sound in here at the moment, but it's just to give you an idea. This is an overall study where it's a very small study. We're enrolling 10 breast cancer patients. And the breast cancer patients are divided into 2 groups randomly assigned, in which 5 participants receive the treatment of just listening to music. And the other participants receive our tool, like the interactive components of interacting and creating music through our app. As I mentioned before, it's enrolling participants, therefore is IRB approved. It's funded by the Brain Tumor Center, this pilot preclinical trial study, but we have in mind going after major funding to keep developing this music therapy tool. And let me state that all the work that we have done with Shoma Singh is done by large teams. This is a number of people that is part of our study team for ARMCAN specifically. So I just want to emphasize that we are many people making this project happen. Our study, the ARMCAN, got quite good news and reception in the news, like even Forbes was talking about, music as the future of digital health. I put a little bit of a snapshot in how UC is mentioned in that really kind of gave us the motivation to keep thinking about more therapy tools. And we questioned what we can do in terms of art therapy. And that's where ARCAN was born. we were trying to think about how can art therapy improve quality of life in patients with vestibular tumors or mood issues. So we recognize that art therapy is well documented and has great shows of benefits for well-being, but digital art therapy wasn't really widely developed. And in times of COVID, we thought that there was a good opportunity to think about how to bring art therapy in the digital realm. And that's where, we develop a robust application, ARCAN, with different self-guided art activities, with pre-post, face-to-face therapy options. And the interesting part of this study is that we involve a patient with such vestibular disease to co-create the application before we would launch it into the preclinical trial. And at the same time, we decided to combine this study with pet therapy. I have quite a bit of work done with robotic pets, specifically for the older adult population, but we question how we can bring robotic pets to also be part of the study for the population. And that's where ARCAN was born. These are some of the robotic pets that I work with, developed by Joy for All. I have a different NSF grant that is focusing on how to expand the capabilities of these robotic pets. I'm specifically designing a smart harness to be a communication tool between caregivers, patients, doctors, etc. But for this specific study, we wanted to question how, we know that this robot has a positive effect on patients and through the interactions, the behaviors, how we can bring them to this population to monitor the quality of life. So you have a picture in here of a basic smart bandana that allows us to understand interactions of people with the robotic pets. And we are measuring, the number of interactions, the frequency of interactions, and we are matching it with the research tools that you see depicted in this basic diagram of our research study. So just like with ARMCAN, we are enrolling 10 patients, and in red is IRB approved. We are currently enrolling participants. We're randomizing participants, and 5 of the participants, we're giving them a therapy, our app, the art therapy app. And in group B, we are giving them both the PET and the art therapy. And it's a 12-week studies. We're using a HAM-D pre and post measurements and a mental health quality of life throughout the study, just like in ARCAN. And we have we are working actually. Sorry, I'm rambling here. So the ARCAN and ARCAN is funded by the Jury Core Fund, but we are working at the moment in this solicitation that you see on the screen. We're trying to advance ARCAN as a mindfulness-based digital art therapy applications for long-haul COVID-19 patients. So we're hoping to submit this grant by sometime in May. Yes, May 7th, well, something like that. So anyway, this study also has been getting a lot of attention, which validates the need for these products, the interest for these products, and it gives us motivation to continue thinking about other therapy tools. And one of the new ones, this is the study team on our art therapy application. Our art therapist, Dr. Mira Rastogi, excellent, has been guiding the entire design of the activities in the app. The latest one, which is very exciting, is based on writing therapy. We call it JotCan. So it's very interesting study because we're trying to advance poetry and artificial intelligence to help us understand writings of people and bringing poetry based on the writings, and at the same time, at the end of the study, using AI to generate poetry itself. So we understand the value of poetry, boosting memory, journaling, having the therapeutic value. But again, the opportunity is like how we can bring it to the digital, realm. So we are trying to ask the question: how can writing therapy improve quality of life impacted in subjects impacted by cancer diagnosis or a relative with a cancer diagnosis? We did a pre-pilot with ourselves to understand the length of the writing therapy interaction, the type of interaction, and how AI was creating a poem based on our entries. And it was so interesting and influential to see the outcomes of our writings to the interpretation of artificial intelligence. So with this project, we are developing the application at the moment. You see some of the screenshots of our JotCan application. And we had just finalized IRB to submit the protocol similar to the other studies. We're hoping to enroll 20 participants, not 10. Randomize them and using the same endpoints, measuring tools. And we have two groups. One group will be 10 subjects will be doing daily writing activities from prefix weekly prompts, versus the other group will use our application in writing based on a prompt that is generated by the subject's writing. And at the end, as I mentioned before, we'll have an AI generated poem based on the patient's entries. This is not funded. However, this project is, we have been selected to go to phase 2 in the Cancer Survivorship Grants, but it's something that we are looking for support and moving forward with. And I think is a very exciting tool to tell you the truth. All right, and this is our study team for the JotCan application. So anyway, so this is to us the future of digital health in terms of designing applications, ARC and JotCan. We are thinking about a future therapy applications, like how we can come up with an ARC application for kids, for example. It's a new application with new challenges, new variations. We're thinking about sketching applications, which is different than our therapy applications. So we're, with our collaborations with Shoma Sengupta, we have started to create this suite of our therapy tools that allows us to, again, put the health at the hands of people, as we always say. But I think the emphasis on these different tools that we have collaborated is that transdisciplinary matters. We wouldn't be able to come up with amazing tools if we wouldn't be collaborating across disciplines and with both faculty and students to generate these tools. And digital health matters. We wouldn't be able to come up with these applications if we wouldn't be thinking about how to creatively use digital in the broad sense for the health and well-being of people. And the last point that I want to make is design, designing the equation of our research projects, like research through design practice matters. We always think about designs as a logo or this, but putting a designer in at the table of a research study is about envisioning ways of interacting with people, designing things for people, even if it's just a simple data gathering tool. We train, we are trained designers, planners, architects, artists to questions, to reformulate situations and to really advance or improve situation into desirable ones. And there are so many ways that we can increase our practices through design. So that's all I have for you. I hope you enjoyed the presentation, and I'll be happy to answer any questions. Let me stop sharing.
Thanks, Claudia. There was a lot of great feedback in the chat.
I kind of stopped sharing. There we go. Okay.
Okay, take your time.
Did I stop
All
sharing?
right. You did. You did.
Excellent.
All right, Geoffrey, you are up.
Thank you. Let's see if I can continue the streak of success.
There we go.
Awesome. So, hi everybody. I'm Geoffrey Pinski. I'm the Assistant Vice President for Technology Transfer. I'm here from the Office of Innovation. As you can see in my background, I'm in 1819. For those that have been around long enough, it used to be the surplus, and before that, it was the first Sears in the city of Cincinnati. And we have a number of ways that we are helping faculty with their ideas and inventions in general, all of which apply to those working on digital health. So there's 4 major functions of the Office of Innovation that have the potential benefit to benefit you on working on your tools. That includes our makerspace, the Venture Lab, my team in Technology Transfer, and our corporate partnerships team. So let's start talking a little bit about the corporate partnerships team, which is responsible for facilitating relationships with our Cincinnati Innovation District, or CID, partners. Those, I've got the slides a little bit backwards. So here's our partners. I've highlighted some that very clearly have a digital health aspect. We'll talk a little bit more about Include Health in particular. Cincy Tech, who I know Don wasn't able to join us, but Don's company, Clarigen, which is a spin out of Cincinnati Children's, is actually funded by Cincy Tech, along with a number of other local companies that have that health, life science sort of aspect, including Core Data. But going backwards a little bit, so the partnership team is here to help connect the partners with us at the university. That includes helping and working with faculty on their research projects. If there's a place where there's an overlap, having the faculty do expert training and skilling and facilitation for those corporate partners, and then as well connecting those partners with our students, right? Whether it's professional development or opportunities to explore in innovation challenges, such as the speed networking, or a tech challenge on one of the things that they worked on over the summer was a tech challenge with Drive Ohio on the future of drones and unmanned, manned, but drone-based flight in the state of Ohio. As I mentioned, there's 4 big ones. The CID is about partnering, or the corporate partnership team is about partnering with our corporate partners. The Venture Lab, for those that aren't aware, is the group at UC that is helping faculty who have concepts that could be startups to learn more about that. Brett, and I'll talk a little bit more about Brett as well, but Brett actually went through this and certainly at multiple points launched a company in the middle of COVID. Not a great idea for anybody. But the Venture Lab is focused on taking early ideas and helping turn them into big ideas. There's a pre-accelerator that takes 7 weeks. Claudia has also gone through this as well. Before I forget, the 7-week process is about refining that idea, learning things that you probably have never really thought about or explored with customer discovery, understanding what your customer actually might need, not just what you think they want, by talking to the customer. with that, with your digital tool, taking that and having that conversation with a customer who might be the one that is the end user of that. Understanding how to position your concept so you actually are sharing the right and key value points. After that, that's 7 weeks of every week having a conversation with those going through the program at the same time, learning and exploring that technology, that concept. We have graduation, where you get to share that idea with with our community, where we've brought in a number of entrepreneurs, others in the community that are looking perhaps for their next opportunity. Maybe they're looking to invest, with the idea that you'll be able to find and build that team that will help you take that idea to the even further next step. And then assuming you have an entrepreneur and you've recruited one and able to take it forward, we then have funding for development. So there's up to about $215,000 right now to help that team further develop it. Now, it's not about the research, it's about actually taking that research and that concept and developing into, hopefully in a year, a minimum viable product, right? That first product that can be then launched and shared. So that is our venture lab, and we've continued to have a variety of different health-related companies, health-related ideas go through that. And then we have our makerspace. Now, it's about taking the idea and making it into a physical embodiment, but they're also slowly but surely building out some of the capabilities around digital and helping with, I think long-term in the future, we'll start seeing more digital efforts. Before I forget as well, the Venture Lab currently is piloting with Cincinnati Children's some exploration around how to better help the development piece of faculty ideas in the software space. And I saw that Matt Wortman, or my colleague at Cincinnati Children's, is on the call, and he's working with us to try to explore that as well. Now that leaves us with my team, technology transfer, right? And we're here along this little path of trying to help those ideas to impact, right? Many of you, I know, have seen names that I've recognized on the call, come with us with the idea, and we try to help with a variety of things, right? Number one, is this something that we can protect? How do we protect it? What do we do with it afterwards? And then our role, in a lot of times, is to connect, right? So if you have something that you think could be a startup, we're going to connect you to the Venture Lab and make sure you start working with them to understand what that could look like. We're going to help protect it. Is this something that's patentable? Is this something that's copyrightable? How do we do that? And then hopefully we're going to find somebody, whether it's you as a startup or an existing company that wants to further develop it, we're going to license it to them. And then we're going to help them commercialize it. And we're going to make sure that the university and yours as the creator rights are protected as that technology moves into a product, and the revenue comes back, hopefully, to the university and then back to you as that creator. This is our team. Jill and Thais are probably the ones that you work mostly with on the life sciences, although I know Maddie works closely with the College of Engineering, which has overlap both through biomedical engineering and a variety of different partnerships that the faculty have developed with the College of Medicine. So you've heard me, and I think I've this is the high level. Let's take it down to some examples, right? So there are a variety of different ways that we can help you generate that impact, right? You're going to go out, you're going to publish, you're going to educate your students. That is the primary mission of the university. We're here to help if there's a further opportunity to create impact. That could be through code sharing, right? So you have code that you want to make sure that others use, but use respectfully. Whether that's open source. So if you have code that you want to share open source, we have as the university owning that code, we want to encourage, and we have encouraged faculty to share their code in an open source fashion, and we can grant and create permission for you to do that. If you want to share it in a closed source, say you have a colleague at another institution that you've developed a piece of code that they want to use, and you don't want them necessarily to share it with anyone else, we can help with that. In addition, we can help, as I mentioned, our primary goal and primary mission is focused on this commercial piece, right? Is to help you transfer that intellectual property to somebody that perhaps is existing, or perhaps it's to a new startup. And you've heard me say intellectual property. What do I mean by that? In digital health, there's two primary places, right? It is copyright and patents. Just with the narrow focus, patents are intended to protect a novel problem. When we're talking about this, it's probably a very novel process, and that process, a novel and non-obvious process that is adaptable. So what we typically do not simply patent is software. What it would have to be is some form of algorithm that's highly adaptable or highly focused in such a way that algorithm would be the basis for multiple pieces of code down the stream, right? So it has to be very broad and very detailed, whereas a piece of software, we can license just as is. So, and why do I say that? Well, so easy example, right? You've developed a piece of code, you've developed an algorithm there as well, but the algorithm really is been published, it's out there, so it's not necessary, it's novel, but perhaps it's not obvious, but your code is showing, 10% faster results, or, this amazing correlation that no one expected. Now, if we were to file a patent on that, the patent's going to take probably 6 to 8 years to get. In the meantime, if this actually went down a commercial path, you're looking at code that is changed 3 to 4 times, has been rewritten 6 to 8 times. So and you've gone down a completely different direction. So what we do there is we protect it through copyright. And copyright's great because it's cheap. It doesn't actually cost anything to protect, other than to enforce it if someone takes your code or runs, takes that code or does something with that code that you're not inclined to have permission to. So what you'll hear with intellectual property is both patents and copyright. And we would, depending on the tool, we'd happy to have a conversation as to whether or not the patent or a copyright pathway is more appropriate. Now, with that said, those are the examples. Let's talk about details. And we just heard from Brett a little while ago. Brett's on this list. Brett and his group developed a photo sharing app to help connect isolated seniors with their family called Hi Lois. They launched as a company, and it is, Brett, I mean, you can nod if it is. It's still out there, right? It's still, but no, it's no longer available. You shut it down, did you?
Yeah, a lot of complications. Long story, unfortunately. Unable to pursue. But
well,
the experience was great, though. I mean, it's amazing.
No, and that's what happens sometimes. And that's still, I mean, to Brett's point, that's what we still want to support. Right? If you think you have something, we want to make sure that it has that chance to have that impact. Because if Brett didn't go down this path, it would have simply sat there and never had the opportunity. And everyone, I'm sure Brett would sit there and wonder what would have happened if I'd not done this. Other folks that we've worked with, Dylan Steen and his team, have developed High Enroll, which is a clinical trial recruitment and retention app. They're out there working with UC Health and working with St. Elizabeth, trying to encourage more clinical trial sites to sign up and use their app. Include Health originally started a universal fitness equipment by Ryan. Ryan was back to Claudia's point of having a designer. Ryan was a senior design student. He did this as his capstone. He developed this concept. The universities, by him using university resources, we had an ownership stake in the technology. We released it as a student. undergrad particularly, that is using university resources, if we're not actually putting real money into them, we release the technology because they need to have the obvious, they paid for the right to be here. But at the same time, we help connect Ryan, right? The university actually invested in this company. We connected him to Cincy Tech, and from there, Ryan has developed this company from originally called Include Fitness to Include Health, and subsequently they've licensed intellectual property from the University of Cincinnati and Cincinnati Children's. So Michael Riley, Adam Kiefer, and Greg Meyer developed an augmented reality for neuromuscular training that they licensed and have been developing as part of their product suite. And that is digital health, right? You have clearly an augmented reality, right? Going back to Sonny's work earlier, right? Augmented reality, simulated reality to train. And then more recently, we have another DAAP student, Abby McInturf, who developed a company called Band Connect. And Abby has gone through the venture lab. Through that venture lab, she found a CEO, and her and that CEO have partnered to develop this company. Originally, it was the original version of Band Connect was neck strengthening training, right? It was about helping, their original study was focused around soccer players and helping them with concussion through neck strengthening. Since then, as they developed that concept, they did their customer discovery, recognized where the true value of their digital health tool was, and it turned out that it was actually best suited for an app-based platform for physical therapy. So that way, physical therapists can ensure, you don't have to be at PT to recognize that, hey, did you do your exercises today? Have you fulfilled the compliance aspect that makes physical therapy in many cases a significant challenge? And then, so those are where we've helped, and we continue to help others. We've got a team working on AI to take mammograms and recognize cardiac health. And we're helping, they've gone through the venture lab, they've found a partner, and they're working right now on that development piece. And there's countless other folks on campus that we're helping. One other thing, and I didn't think about this, I was focused on getting the technology out the door piece, but one of the things that where we do help, and goes back to Brett's earlier conversation about some of the tools, is we have responsibility for de-identified data use agreements. So if you need a data set that is in fact de-identified, not a limited data set, that has to go through legal, but a de-identified data set, our office has the responsibility to handle those, and we can help get those through and signed as quickly as we can. So with that,
Great. Thank you, Geoffrey.
Thank
Appreciate
you.
that. Okay, well, I'm going to go ahead and share because we're going to go ahead and take a break now. 5-minute break. Excuse me. And during this break, Sonny asked me to try again to share the video, and would love to do that.
I did?
Because... What'd you say, Sonny?
Did I really?
Well, let me try, because I do feel bad but everybody else go ahead and take a break if you'd like to. Let me unpin and bring it back to the gallery. Because I do have a video for to listen to kind and soothing music during the break. So 5 minutes, we'll come back and start the breakouts. If you didn't see my chat, you get to choose which breakout you get to go to and talk for the next 30 minutes, starting at, we'll say, about 10 of, and you choose the breakout you go to be with the panelists from
Stephanie,
the
did you put
presentation.
the instruction?
I will do that after the break.
Okay.
And I'll put that in as I'm putting the video together.
Okay.
Yeah, trying to do a couple things at once here. And at that time, you will also, I hit send an error. Okay. Anyway, at this point, go ahead. We'll take a break. If you'd like to listen to the video, keep your video on or what have you. You can be muted. And then we'll come back and I'll put you into the breakouts that you choose. So this is not something you don't have to do this. And then we'll wrap it up with Jack. Thank you.
Stephanie,
Yes.
I just want to remind you, I have another meeting immediately after
So do I.
this is scheduled to.
Yeah.
end.
Jack, we know we're running late, but we're gonna stop on time wherever we are. We may run the breakout a little bit shy of the full 30 minutes, and then you actually have 25 minutes for the large group discussion, and we probably don't need all that.
Okay, I just wanted to let people know that I'm heavily scheduled today, so
Yeah,
I don't.
I'm in that same meeting
Yes.
with you, bud.
A lot of flexibility.
Yeah.
All right.
And if I can
So
get this one,
my
video
next
area,
schedule-
of course.
My next meeting is scheduled at 11:30. Laura, did I hear you say that you're thinking about canceling the noon debrief? Is that on or not on? Still on my schedule, I noticed.
I haven't canceled it, but we can do it without you and update you later.
Okay.
Oh, no.
I may stay for a little bit of that. I've got another Rashmi meeting, and then I've got to come in.
Okay, and I'm gonna join you at 11:30, so we'll both be at that one
Okay.
to meet with researchers.
Okay, my internet is off. I'm offline now. So Laura, can you
Oh, let me go back.
are you able to share?
Let me see if I can bring it up.
How can you be
I'll stop
offline?
sharing. I don't know.
Stephanie, I mean, you're here, right?
I know.
Don't you need the
That's what it's
internet to
telling
be
me.
here?
You are talking to us, Stephanie.
I know. Well, it's saying my
And you're
the
playing
server's
music.
down. Did it start playing music already?
For a minute.
It tried.
I know. It says video error, so I can't load.
Okay, I can,
Internet
let me try.
connectivity. Go ahead.
Stephanie, let me try. Can you see that?
Yes. Perfect. Thank you.
I need to sign in and go to my cot so I can get warm and sleep.
Excuse me, you need to back up off of me with your coughing.
Who died and left you, God? Let me go to my bed and get my stuff I left here.
Hey, lady, you want some company tonight?
Get lost, jerk.
Oh, come on, you know you want it.
I said get lost.
You old hag, you're lucky to even get an offer.
Sharon, is that you? Sharon, can you hear me? Do you remember me? I'm Alexis, a case manager. We met once in the hospital. It's been a while.
Hello, can I have your name, please?
Don't answer. She's one of them.
May I have your name, please?
This is Sharon Taylor. She has an appointment with Dr. Johnson.
Not now. Shut up.
Sharon, it looks like you may be hearing someone besides me talking to you right now. Is that what's happening?
No.
Move it along. Are you sure you aren't looking for anyone? There's always some of your type on this corner.
Good morning. I like your dress.
Don't ever talk to that person. He is not right in the head.
Tranny.
Glad you're here today, Krista. How did you hear about our practice?
One of my friends comes here, and she's trans and has the same insurance as me.
Okay, let me grab a few things first, and then we can leave.
is all the information from the pediatric neurologist, psychiatrist, physical therapist, and your other specialists. I think that's all the new doctor will need. All right, let's go. We have to go and meet your new adult doctor. I'm sorry that was such a long drive, Brian. That is always hard for you. But look, we're here now. Brian Xavier Mercer. I'm sorry we're late. All of your accessible parking was being used.
I can answer some of these questions. I have the buttons on my iPad. Where are they? There they are. Why didn't they wait on me to answer? I can still try. She is talking too fast.
Thank you, Laura. That's great.
That worked good. So
well
this
done.
afternoon, she's going to show like a 20-minute one to ODM and GRC and all the other letters, people with letters.
Well, who are they? I would be interested to know who's ODM and GOC.
Ohio Department of Medicaid, Government Resource Center. Then
Cool.
Government Resource Center and ODM have their own advisory team of like patients with lived experience, caregivers, and then we have our patients with lived experience who are arguing with their patients of lived experience. And no one with lived experience likes that, putting that law in front of, you know, all the transgender, not just ours, but I mean everyone's. In fact, ours was the only one apparently that didn't have to be toned down. So I don't know what the
Although
other
Sonny, that was the first time, even I'm on the team, and that was the first time I saw some of the corrections and updates they made.
Yeah, yeah.
And it's amazing. It's just coming along so well.
I know, right?
Yeah. I mean,
it'll be interesting this afternoon to see what they show.
yeah. Can't wait till the programming's all the way done.
Yeah, it would be nice.
It's amazing. It's really nice.
And of course, we were all stars since we were the voice actors.
Oh, wow. How cool is that?
Yeah.
She's just talking about herself.
And a lot of us. Almost everyone was one of our team. We wanted to have CCM acting students, but we just couldn't get it. The organization was too hard.
No one would be the guy who propositioned Sharon. Nobody wanted to be that guy. Nobody wanted to be the teenagers. No one wanted to be Brian. That was the big thing, because they didn't want to make any weird sounds, like some people who can't speak and they get frustrated, so they'll make sounds, especially like in the waiting room where it's supposedly really crowded, and nobody wanted to play that part.
I think
then
everyone
ODM took all the sounds out, so it was like, okay.
Everyone was so scared of being offensive, even though the patients and their parents that we interviewed said, that is what happens sometimes when they get frustrated or tired, overtired.
And the mom who played the mom is a caregiver of a child at Children's with disabilities, and Crystal is a transgender woman, and she was like, well, she swore a lot and they had to take that all out. So she didn't like the way people, she didn't like the way the staff was treating her. And so she acted like she said she would act under her breath. And then ODM said, no, we can't have that. That's offensive. So, oh, well.
Okay, I think we're ready to start the breakout rooms.
Yes.
I apologize. I'm going to jump off because I have to be on another meeting in 15 minutes or whatever, 12 minutes. So it was a great presentation from everyone. Thank you.
Thank you, Mary Beth.
Thanks.
All right,
how do we know what breakout room we're going to?
Stephanie has put the instructions in the chat.
Is that breakout?
So I'll put the panelists in their own in your own breakout.
Yeah, we'll get you there.
That kind of helps, right?
I wasn't sure.
Yeah. Let me do that first. And if you can put your video on for just a second or unmute yourself or put a little reaction saying you're back, that'd be great so we know to get started while I'm putting the panelists in their own rooms. And then we're off. I will
And
open
then as
them
people
up.
come back, they just have to click on the breakout room link at the bottom.
Yes, does everyone see the breakout
So
room?
yeah, you need to know we're not putting you in a breakout room. You need to put yourself in a breakout room.
Yes.
I see it says breakout room 30 minutes. Is it
Yeah,
breakout?
no, we're
room?
putting you in a room. Don't worry, Sonny.
Oh,
That's what it's for 30 minutes, but I have the instructions here on the screen.
okay.
But I also put
Now
the
I
same
see the
instructions. Yeah, and then I put it in the chat. So I'm going to open all rooms and choose where you would like to go. Sonny, Brett, Claudia, and Geoffrey should go to their own rooms. So they have an option that should pop up on their screen. If you need assistance, just unmute yourself and I'm happy to help you.
Okay, people are moving into their rooms. Great.
They are.
Awesome. Stacy, you're not going in a room?
I sent you a chat to see if you wanted me to go to a specific room.
No, you,
it's up to you.
It's up to you if you want to do it or not. I don't, I think I was going to pick one also.
Okay.
Yeah, I'm here in the main room, so you guys do what you want. Jack, you're welcome to join a room if you like, but you don't have to. You're not mute, or you're muted, I should say, but you don't have to.
At
I'm
this
gonna
point,
go
I'm
get
just
some
trying
coffee.
to get some other things done and get
Totally
caught up on
fine.
some
I
things.
just wanted to let you know.
Okay.
I'm gonna go get some coffee if you don't mind. If anybody comes back and needs help.
I'm gonna go do that. I'm gonna do that as well. It shouldn't be very
Okay.
long, but I will hang out here.
Well, no, we can both do it. These two seem to not be hearing the instructions, so, or they're just wanting to hang out here, so. Go ahead, you
Okay.
can go first.
All right, I'll be right back.
Okay, sounds good.
Okay.
Oh, thank goodness.
Thank goodness.
Yeah, nothing happened. My
You
my
got logged
internet
on.
is like rebooting itself.
Oh, that's weird. Well, I can't help you. I'm
No,
not,
it
this is
it
not a place I am good at.
I know. Well, it fixed itself. All right, Laura. So she wants me to send 15 more minutes. Okay, broadcast. 15 more minutes. Jump around if you like.
All right. So that's not what I should be looking at. I should be looking at this one.
I don't think people want to jump around. That's the thing. But
all right, I'm trying to get caught up here. I have no idea. All right. So, we have time, obviously, for discussion when they come back.
yes, she wants us to come back bring everyone back after the 25-minute mark, 15 more minutes from now.
Really?
Yeah, so like at 11:15.
Fine. 11:15 is good. So.
Do you know what to
do?
To discuss?
Well, the short answer to that is not really. I mean, that's the short answer, right? So
That is the short answer.
You've got four. You have four different.
Does she have any notes in here?
Disparate topics, yes, but it says, I hope everyone had an opportunity to share the ideas and connect with people, blah, 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 blah. Now we would like to open up the floor for discussion. Please raise your hand. I don't think that introduction is enough to really start a discussion. I think there are a couple ways to go with this, Stephanie. You know, one is I mean, we're going to have what, 15 minutes, correct?
Yeah, I mean, we want to give any more questions. I mean, I guess they're talking questions now, but she has a slide here for questions and feedback. Can you see this?
I'm looking at it. Yes, ma'am.
Great.
So here's my thought. So, because we have people in 4 different rooms, which of course makes perfect sense.
Yep.
You know, opening up a discussion about any one of those begins to exclude the others, and then we have sort of siloed discussions. I think I would. This is a pretty far pivot, but rather, so I can do 2 things. I'm thinking I can do 2 things. One is to say, look, we've had some very interesting discussions here about some very different aspects of digital health, which is clearly becoming an important part of our approach to health in general. Whether we are on the delivery side, the research side, the receiving side, the community, the community side, you know, for different organizations in the community, digital health is, different aspects of digital health are very important. So, are there any sort of observations? So I thought I would start by saying, are there any sort of observations that you see in this general space? Perhaps something that we missed, some aspect of it that was not really discussed today, that the 4 different presentations might be able to speak to, or perhaps something that wasn't brought up at all that we can think about for a future a future event on this topic. And if we don't get anything there, or even if we do get a few things, I thought what I would do is pivot and say, look, this is a platform that we can use to approach any topic that has broad interest, and where we can organize some interesting presentations like we have today, so that people will be able to come together again to talk about other areas of interest. We generally stay within the health field, but we certainly could go beyond that. But what are some thoughts you have about what we could do for future sessions like this, and just
Yeah.
get people's thoughts?
That's awesome. And they can always, if they don't want to spend time, they can always put it in the feedback, like in our feedback survey.
Well, they can put it in if they don't like to unmute themselves, they can put their comments or thoughts in the chat.
But if they don't have time, we can, that's why we have the feedback survey too. So
we are, we try to do
multiple
several
ways
things a year, and we like to be able to get input from people that would consider attending something in the future. So let us hear what other topics you would like to have us broach in the future in this space. Hi, Laura.
Hi, I can barely hear you, Jack. And if I turn you up, I hear this like droning noise.
No. All right, so let me.
He just has to click on something. He does something like that.
No, I don't.
There you go.
Is this better?
Yep.
How about this?
You gotta. Yeah. Either
That's
one.
better?
Mm-hmm.
Yes. Much better.
Noise.
It's this.
Oh.
Hang on.
Yeah, that really does work.
Okay,
so
this is actually, I'm just taking the little muffler off of my remote microphone that I use with my camera when I'm taking
It does
videos.
help a lot. I've even had to put because usually I have you up on like 100. Now I have you up on 50, just on 50.
I have to turn you up and then turn you down when other people are talking, and then turn you down.
Okay, well,
yeah,
I
so it's
apologize
perfect
for that. I mean, I've gone to this external microphone because the quality of the microphone is better.
Yes.
But if it's not working, but it is working now, you're saying?
Yes.
It's not great, but it's better than it was.
Well, all right.
I think it sounds good.
Because I can push more buttons. Believe me, there are buttons here I can push. Well,
Yeah.
Where'd all my buttons go? Hang on.
Hit escape if you're, sometimes escape.
No.
I hide my buttons sometimes, and that's why.
Well,
Laura,
the buttons hide from me.
Yeah, that's true. Laura, I put in the chat the feedback, but you might want to send that out to, do you want to send this out to everybody? Because we can, the feedback to all the attendees.
In the chat, yeah.
But for those that attended that didn't stay throughout the whole presentation.
Yeah, we should send it to everybody.
All right, let me see if I can send that. I'll work on that right now. And I was going to close it at 11:15.
Okay.
So
All right,
5 more minutes. Let me broadcast another message saying 5 more minutes.
Are you hearing me at all now?
Yes.
Is this good, bad? No. Let me go back to this.
I liked the first way, but yeah, you're fine to me.
The difference is you may have him turned up. I have it turned down a little bit because you're very loud and he's very quiet.
Oh.
I'm set at.
Where are you at on the speakers?
Right.
I'm at 29 and you're really loud.
Okay, well,
I'm still loud.
If I go to 50, then you're too loud and Jack is okay.
Okay, I'm at 29 as well. How's that? I'll keep it at the same as you, and then we'll
is your
see.
output. I'm not sure how you can turn down your speaker. I mean, turn down your mic. I don't know how to do that.
Oh yeah, that's true.
I see. I can do it in some platforms and not in others. No, that's not working.
Excuse me.
Yeah, that even when you're typing, it's really.
All right, where's my settings? And I'll try to.
And maybe that's where the noise is coming from. Because your mic is so loud. There's feedback.
I am hearing.
Yeah.
I am hearing sort of this droning.
Yeah, it's from Stephanie because her mic is turned way up. Oh, that's better. What'd you do?
Yes, that
Oh,
did
you
get
muted
better.
yourself. That's why.
Well, there you go. We fixed the problem.
That's quiet now.
Okay. All right. Is this better?
Yeah, Jack, you're fine. It was Stephanie was too loud. It was the opposite.
Okay. All right. I have a technological fix here. We'll just call it, for lack of another term, we'll just call it a box of tissues.
For lack of a better term. Okay. Yeah, that'll work.
All right. So this is my box of tissues fix.
Okay. Stephanie's playing with her mic, I think.
Yeah, it seems like I should.
Actually, we only have 8 minutes left, and that'll take us till 20 after. I can. Is that?
Stephanie,
Do you,
need to lower your mic. That's
Okay.
really.
Menu options, request, Zoom, remote control, annotate. Reactions, live transcript, chat, bunches of other stuff, recording, original sound on.
Yeah, you're okay, Jack.
Okay, I'm just looking for more buttons to push.
Oh, then you're gonna, you don't know what's gonna happen if you do that.
No, you're right. I don't, and let me push one more button. I can unpush it. Did that change anything?
No.
Not a thing?
Nope.
All right, that's my.
You are sitting a little low in case you're interested.
I'm always sitting a little low. Well, there's another way to look at that. I'm just
There you
sitting
go.
camera high.
That's, well, yeah, maybe not. Well, that's fine.
Yeah, I mean.
Oh, perfect. Perfect.
Okay, there we are. So
Like the eyes need to be at the 2/3 level. It's television.
I'm sure there's a law about that.
In television there is, yeah.
I am fine. So I'm going to go with right now the microphone that is attached to my camera, but I have this other mic. In other, what are we in, Zoom now?
Mm-hmm.
All right, in Teams, I have more ability, I have more buttons I can push. And I don't have very many buttons to push here. It just, that it allows me to go in and change the level of my, how are you guys doing that? Changing the level of
Is that better?
microphone?
Yes. Yes, the
How are you
droning is
changing
gone.
How are you changing the level of your microphone or your speakers?
So I went into
Now it's too loud again.
settings,
That's not part of Zoom.
and it tells you in Zoom. I just took it all down to 75.
Take it down to 50.
Where did you find that?
Go in and just type in settings in your search.
That's still really loud. Is that your mic or your speakers?
Well, it says up here, I have it down to 29 as my, it says for both because it's the master volume.
In what settings? And where do I type?
Let me go back to default.
Oh,
type in the search down here at the bottom.
Am I really loud, Stephanie?
Settings. No, you're fine. You're the same as normal.
I don't have a box that says search.
Oh.
Do you?
In your taskbar? You don't?
Yeah, because you're really loud, Stephanie. I have to turn you down.
In my Zoom taskbar or my computer?
No, your computer taskbar.
All right, I've got a little magnifying glass.
Yep, that's where you type in settings.
Type in microphone settings.
Yeah, I tried that first and it brought me into a web browser.
Oh.
Let me see where we're at. Less than 5 minutes.
Now I've got all kinds of. I can
Let's
just
see
type
here.
Settings, but it gives me. All right, I've got a little cogged wheel now.
Bring people back now.
All right, so I got that far. Now what do I do? All right.
So I've been just pulling them down.
Devices, apps. What do I do? App volume, apps.
Sound.
Account,
Watch the
search,
screen. She's
privacy.
showing you. Yeah.
I know. Go back. All right. So.
Settings.
All right. So I don't have that settings. I have. one that says devices, one that says apps, one that says phone, system, personalized gaming.
Well,
Then do you see the find a setting under home? Type in there sound.
All right, hang on. I need
Sound
to get
mixer
back.
options is what it's sound mixer options.
Okay, well, I can type that in.
It won't let me change the defaults.
Okay, I just did that, and another blue screen is popping up. Okay, I've got one that looks like yours now.
Okay, good. There you go.
Output microphone. All I can do is change what microphone I'm using.
yeah, he's in the PC settings.
Yeah, I'm in PC as well.
Okay, so I can change this, which I think
Am I
presses
better, Laura?
another button.
Yeah, you are.
Okay.
I'll just break them all down
Now
halfway.
it's loud again.
Yes,
What?
it is.
Now it's loud
I'm
again.
Okay, did my microphone get any better or worse or different?
No, it didn't change at all, Jack.
That's because I pressed it there. I didn't press it there. I press it here. All right, how about now?
Yeah, Stephanie, that droning is really loud.
It is groaning. All right, so is this better or worse?
It's the same. You sound like my eye doctor. Is it better or worse? And I keep saying it's the
I
same.
know. Well, so maybe these are just fake buttons.
Yeah, just you're fine, Jack. People can turn you up if they can't hear you. All right, so
Speakers, high definition audio.
we've got 2 more minutes.
Yeah, I can bring yeah. And then quick discussion, I'll put as he starts with the discussion, I'll put the feedback slide up.
Okay.
Which is the next one, yeah.
Okay, good. We're all set.
I was going to say, yeah, I won't talk anymore since it's really loud, and I'll try to figure that out.
Yeah, I'm not sure what's up with that. You've never been that way before.
Yeah, I don't know, because I had to reconnect to the internet, but everything's low. Like I put everything low. How about now?
Yeah, well, my mic, I don't know. I think my mic is set pretty low too, because we're like right next to them.
Yeah.
All right. Well,
How about now? Because I'm away from my computer.
No, I still
You're
hear the droning.
you're better, but the droning is still.
What the heck is this droning?
I don't know. Do
It's
you
some
have a
kind of
drone in the room?
feedback.
It is feedback. Okay. I have to go to the bathroom.
Thank you for sharing.
Thanks.
You're
for
welcome.
that. All right, we'll take it from here.
Can you close rooms, or I have less than a minute, so let me go to the bathroom.
I'll close the rooms when it gets to 0.
Don't they automatically close?
I don't know.
They do.
Okay,
And
then
they
they're
go
going to be
out into
automatic,
the-
and people will all come back, and then
They
Jack,
go out
you
into
can,
the ether?
you can start talking to them as soon as they all get back.
All right. Okay. I've got this other meeting in now 10 minutes. So I want to.
Well, we end at 11:30, and then you and I can both go into the meeting with Julie and Eric.
Yeah, I need to find their file. Oh, that's another file I need to not lose track of. Let me see if I can find the one that I need to find so that I don't lose track of it. Oh my gosh.
And we getting everybody back.
Yes, we were just talking about collaborations at
All
UC.
right. Perfect.
What do we need?
Did you find the answer to that?
Actually, well, we identify some barriers, but also some simple things that we could possibly do. But anyway,
Okay.
yes.
That sounds like a wonderful.
I missed where you're from, Claudia. What?
I'm
originally-
Sonny. Jack, I can't hear you. I know you were talking and you.
I'm
nobody could hear
sorry,
you.
Claudia. I was trying to figure out where Claudia was from.
Yeah, I'm originally from Argentina.
Okay.
Córdoba. I was born in 75. I moved to the United States in 1999. And I've been
I
here.
actually meant department, but that's good to know too.
I'm glad that she gave us that background because I know what department she's from.
I didn't know because I thought what you're doing is so great. I thought Alzheimer's disease.
Oh, where are you from? Oh my God.
I'm sorry.
She's from DAAP. She's from DAAP, Sonny.
Okay. Well, that's what I thought. That's exactly what I thought. I just wasn't...
and before that, before she was from DAAP, she was from Argentina.
Okay. Oh my goodness. I have to say that sometimes I'm very silly. It's like
I'm sorry.
I'm so subconscious that about my thick accent that sometimes people ask me about where you're from.
I love
you have a beautiful accent.
I love your accent.
Okay, if everyone could maybe, Jack, I don't know how you want to run the discussion, if you want people to put stuff in the chat or if you want them to talk about takeaways from their discussion groups.
I thought you guys had a meeting at 11:30, didn't you?
I do. And that's why I'm trying to get this discussion going, Dr. Regan. All right, so here's the deal. We don't have a lot of time left, and I want to cover a couple topics. But one is, this has been a really interesting morning where we've heard from people with very disparate but very valuable perspectives on this topic. And I think rather than try to silo the discussion, I'd be curious if there were any sort of general points that came out of your discussion groups that that you would like to share with the entire audience today. If you feel uncomfortable unmuting and talking, please feel free just to put them into chat. But this is an opportunity for us to sort of pull things from these discussions and make sure that we at least have an opportunity to understand what some of those issues are. We're not going to have enough time to go into discussions here, but I think understanding some of the things that went on in different groups are very important now. So if people from any of the groups would like to unmute or write in the chat important sort of summaries or issues, topics that came up in their small groups, that would be helpful.
Jack, I have one.
Excellent.
Yep. So we're talking to Yu-Chin. I talked about the Trinetics network and publishing. One of the other primary uses of that is to find subjects for recruitment. And if someone's struggling with recruitment, one of the primary uses of Trinetics is to find those cohort specifics that you're looking for, and then you save your query and you share the query with BMI. We can reverse engineer queries and then provide you medical record numbers and whatever, name, address, etc., providing you have the compliance measures in place. So I didn't talk about that in the main presentation, but that's another example of what Trinetics can do. And Yu-Chin, she's actually doing that right now with, she has a project in place, and I didn't know that, so I wanted to just mention it.
Well, I think that's an important feature of what you can do there, because, as we're trying to identify patients that we can do follow-up or talk to them or bring them into clinical trials or anything else, this is a good way to pinpoint some of the people you want to talk to. That's a great point. Thanks, Brett. How about any of the other groups? Claudia, I'm going to call you out because you started to talk about some of the points that you were discussing in your group.
So we discussed really like what DAAP is and what DAAP has to offer for the campus. So I think that was something enlightening for the audience. But we also discussed that it would be interesting to identify a good process or a way to converge where to go if you want to develop a digital, health technology. So we had some ideas. We discussed some points such as, I'm interested in how we can bring resources together into something that we call a Center for Digital Health. Because It's needed. Everyone is doing it. We're just a little bit disorganized at the moment. So, and that kind of led us a discussion to understand that we have many resources to collaborate, but we're still a little bit so much fireworks per se. And what the group does now in terms of helping us network, it works. It's just we want more, and especially in issues of digital health. So, Jack, I'll be happy to meet with you and discuss what could we do. I have some ideas on how we can join efforts and organize I think that's the discussion. So.
I think, you know, not only is that an issue for digital health, but one of the things we all find as we're on this call is that we're from different parts of the university and beyond. And I am constantly going to these kinds of presentations or other presentations where they say, I didn't know that existed.
Yeah.
Or, oh, that was so wonderful. I'm glad to meet you. We need to connect. And those sort of happenstance kinds of connections can be very valuable to us, but we can't really, it's hard to make an entire professional career out of a series of happenstance connections. And particularly since, frankly, we're all within walking distance of each other. And now that we're doing things virtually, not even that. So I think the one thing that is important is to be able to take things like digital health and to be able to create opportunities to have more frequent connections and for people to identify things that they're doing so that we can more easily find each other. And that has been a challenge in any topic we have presented here. That has been the follow-up challenge. How do we keep this going? I would like to meet more people, or I didn't get to meet so-and-so, but I really want to. So that's very important. I appreciate the comment, Claudia. Anybody else?
Jack, Jeff Pinski and I had a long conversation about whether or not the 1819 project was prepared to take on social service agencies and their products, along with non-medical things. These are medical school adjacent. But in reality, most of what you guys talk about, of course, is tied to the university campus, but there are a whole raft of product launchers, low-income housing providers, for instance, in the immediate neighborhood around the university, some of whom need the sort of help that 1819 and its launch workshops could provide, and Jeff is willing to take that on.
Oh, fantastic. Thanks, Jeff. And actually, I'll just tag on to that when we first began talking about creating what became the 1819 building and the ventures that go on in there, these were some of the things that were part of our initial discussions. And I think with all the things that we're trying to do in this space, sometimes we forget that we located not only the 1819 building, but the one adjacent to that, the big one that they're building behind that. We located them where we did so that we were closer to the community, that it was more apparent that we were in the community and not in our sort of closed campus. So I'm glad to hear Geoffrey's willing to pick that up, and we need to try to do more of that. And it's not only that direct connection you have, Stephen, with 1819, it's just better collaboration across the board with how we work between the community and the university. We're always struggling with that. And it's wonderful to have you, Stephen, on a call like this, because otherwise we find ourselves mostly talking to ourselves. And then we talk to ourselves about you. So it's nice that you could join us.
However, you must say the 1819 room was located in a neighborhood of need that is now transitioning to a gentrified neighborhood that barely has housing that's affordable for the people that used to live there. I don't know where they live now.
Well, that's a double-edged sword. We have torn down the neighborhoods we wanted to work in order to work in them.
Yeah. But they are moving into the former Cincinnati Dental Services building on McMillan Street, which is in Mount Auburn, and I'm president of the Mount Auburn Community Council. So we're glad to have them.
Yeah. Well, we are at time, and we do try to end these things on time. I hope that you will. There's another slide that's sort of a follow-up, and I think Stephanie's going to get the slides to you so you can do our evaluation. We like to do these things. This was an important topic to us. We will have more of these in the future, and we will probably come back around to this topic. But we have been trying to touch a number of important topics for our community, and so we try to do several of these a year. Please stay tuned for the next one coming up. It may not be until summer, but we enjoy having you all here, getting to learn what you're doing, and getting you to meet each other. So with that, Stephanie, I think I'm going to ask you to close this out.
Okay. Thank you, everyone. Have a wonderful day. Thanks for your patience today. And yes, it's always good to see faces that are waving at the end. So thanks. Great to see everyone. Have a great day.